All right, good morning and welcome. Buenos dias, bonjour, salam alaikum, buongiorno, magandang umaga, and well, howdy. I'm Jeff McIntyre, the Global Liver Institute's NASH Program Director. Thank you for joining us for International NASH Day 2020 and our panel on pediatric NASH. I'll be your moderator today. Now, this is just one of 6 thought leader webinars being conducted as part of International NASH Day, which is an initiative of the Global Liver Institute and 80 partners in 25 countries. Now, this year, it is celebrated as a virtual multi-platform experience to raise awareness of NAFLD, that's non-alcoholic fatty liver disease for you guys playing at home, and NASH, non-alcoholic steatohepatitis. And what we're doing here is sparking a global movement of action to improve the lives of people at risk and living with these conditions. Make sure to visit our website, globalliver.org, for more great information and resources on NASH and other liver diseases. Then be a part of the conversation on Twitter, Facebook, and Instagram at #NASHDay. Now, I want to give a special thanks to the ASLD, that's the American Association for the Study of Liver Diseases, and EASL, the European Association for the Study of Liver, for endorsing International NASH Day, and of course to our amazing corporate sponsors. Okay, let's get started by introducing our esteemed international panel on pediatric NASH. First up, Jake Mann. Dr. Mann is a pediatrician in Cambridge, UK, with a specific interest in NAFLD. He graduated from the University of Birmingham and after working in Leeds, moved to Cambridge to train in pediatrics. He's currently undertaking a PhD at the Institute of Metabolic Science and is coordinating the development of the European Pediatric NAFLD Registry, something I'd really like to ask you about later on as well.
Sure.
Gina Madison, hi Gina, Gina is the Executive Director of NASH Knowledge outside of Pittsburgh, Pennsylvania. With nearly 20 years of business experience, Gina was named one of Pittsburgh Magazine's 40 Under 40 in 2015 and became the Executive Director of NASH Knowledge on June 1st of last year. Dr. Major is an associate professor at the University of Alberta in Edmonton in the Department of Agricultural Food and Nutritional Science. She does research on nutrition, diet, and pediatric gastroenterology. And Jennifer Panganiban. Dr. Panganiban is a pediatric gastroenterologist with the Division of Gastroenterology, Hepatology, and Nutrition, and the director of the Non-Alcoholic Fatty Liver Disease Clinic at Children's Hospital of Philadelphia. Her research focuses mostly on NAFLD, obesity, and weight management. All right, welcome everyone. We have a big topic in a short amount of time, so let's jump straight into this. Dr. Mann, I want to start with you. Let's talk a little bit about pediatric NASH and NAFLD. What is it and kind of what are the unique aspects of treatment for it?
So pediatric NAFLD or NASH, the key feature of it is buildup of excess fat in the liver, and that is very closely linked to obesity. Now, I think we're all here aware of that obesity has had a lot of media coverage and hopefully has percolated down through the population, so people are aware of the risks of obesity in its link to type 2 diabetes. But the kind of simple way to think about it is that with obesity, as your fat stores fill up, you then have excess energy, which has to go somewhere, and then it often ends up in the liver. And that can, over time, then lead to injury to the liver, building up to scarring, and then over a long period of time, usually, in some people, can lead to severe end-stage liver disease. And we, as people involved in looking after children with NAFLD or researching it, I have noticed that this happens in children as well as in adults. So it's a condition that we feel needs attention and further research and working towards appropriate management.
We have seen a real explosion in childhood obesity, especially since the 1980s, and with that has come about in the rise of other concurrent conditions, diabetes, type 2 diabetes, hypertension, high blood pressure. Dr. Panganiban, talk a little bit about how you manage this. How do you diagnose, identify, and manage this within your own clinic?
So, in terms of diagnosis of fatty liver disease, you start really with getting a baseline ALT. So NASPGHAN came out with guidelines, which is basically the North American Society for Pediatric Gastroenterology and Hepatology and Nutrition in 2017, and they suggested screening patients for 9 to 12 years of age who either are obese based on CDC growth charts greater than the 95th percentile for age and gender, and then, or they're overweight with risk factors, insulin resistance, dyslipidemia, central obesity, type 2 diabetes, and then earlier screening for patients who have risk factors or severely obese, has a family history, and then consider screening for those siblings of patients that have NAFLD. So in terms of like diagnosing NAFLD, it's really based on, getting high index of suspicion clinically, history, and then also getting labs. So an ALT that's greater than 22 for girls and greater than 26 for boys based on kind of the NHANES data. And if you think it's greater than a 2 times upper limit of normal, then you can consider, NAFLD. In terms of comorbidities, like you were mentioning, I think that's the biggest thing. We rule out other liver diseases to ensure that the diagnosis is NAFLD, but we also screen for other comorbidities. That includes getting a lipid panel, that's a fasting lipid panel, to look for cholesterol issues. The typical pattern in NAFLD is dyslipidemia with a high triglyceride level and a low HDL. And then we also screen for type 2 diabetes. And we also look at other comorbidities, and vitamin D deficiency is very common in kids who also have NAFLD.
Dr. Major, I want to turn to you real quick on this. We know one of the many linkages to childhood obesity has been the poor state of childhood nutrition, especially in terms of access. You've done a lot of work in the area of nutrition. Talk a little bit about where nutrition comes into play here. I'm curious about environmental instances and about, is there a nature-nurture aspect of this?
Sure. So the mainstay of treatment right now for pediatric NAFLD is lifestyle modification. So the recommendation is for weight loss because that's been associated with improvements in liver function in kids that have NAFLD. But as you know, that's challenging. Plus the natural state of the course of things are for children to increase in height and gain weight. So weight stabilization is usually the first approach. From a family perspective, that's really important because you need the family involved in the overall lifestyle change. The family needs to walk the walk with the child and make sustainable lifestyle changes. And that's a really hard thing to do because the environment is full of advertisements, the food supply with high fructose corn syrup containing foods that are present in baked products, sweetened sugared cereals. And so that can be challenging for the family. And definitely feedback from in our research studies and in our clinic at the University of Alberta has shown that families do find it challenging to walk the walk with their children. Often they will buy separate foods and talk to their child about how you must be on a diet, and that doesn't work for kids. They really need to have a family-based approach to treatment where you include the parents in the change modality of their diet. And really it's important to really focus on sustainable lifestyle changes. So our approach in clinic has been first to look at added sugars because high fructose corn syrup has been associated with an upregulation of fat synthesis in the liver. So we're really focused on how much sugar-sweetened beverages do children drink, or the sugar-sweetened cereals or the baked products. And we really focus on healthy food choices like fruits and vegetables. And right now, in the short term, we're focused on isocaloric diets, meaning we're not trying to focus on weight loss per se, unless it's quite a severe level of obesity, but rather in changing in dietary patterns first with both the family and the child. So that means increasing more fruits and vegetables in replacement of these added sugars that are present in other foods. And that's the approach we take now, an isocaloric approach with a fructose reduction strategy along the lines of those added sugars.
Yeah, that's a great segue to Gina with a NASH knowledge in outside of Pittsburgh. You're really kind of on the front lines in terms of educating and approaching parents and families and patients, supporting them as well. Talk a little bit about this in terms of pediatric NAFLD and NASH. What are you guys doing? What resources are there? What is it that you face every day when you're dealing with this?
Sure. So we started our organization to raise awareness about this disease in general. And we found that with the rise of pediatric NASH and NAFLD, that's really a great place to focus. So what we're really doing is we're just working to really get awareness out there. We really believe that if we start with children, we focus on partnering with schools, with pediatrician offices, going to child-focused events, working with child-focused organizations. We can then impact the entire family and start to raise awareness. And as Dr. Major said, it is about a lifestyle change, and that's very difficult. But we believe that if we really just start with the awareness and the education, that's really the best place to start. We've also found that there are not a lot of organizations right now that are focused on the childhood aspect of NASH and NAFLD. So that's why that's really a priority for us this year, and working with different organizations to just really get the word out. As you said, Jeff, you hear a lot about obesity and diabetes, and NASH and NAFLD seems to be a missing piece of that story. So that's just kind of get access to folks and really just raise awareness and start to educate folks, and hopefully over time, it'll sink in and it'll be a household name, and people will be more aware of it. And hopefully as we do that, we will be able to decrease the prevalence as well, because folks will start to understand the steps and what they can do to either reverse the disease or to prevent themselves from getting it in the first place.
Dr. Major raised an interesting phrase there of walk to walk. And so Dr. Mann and Dr. Panganiban, I want to go back to you guys to talk about this a little bit. When we're talking about lifestyle interventions, is this something that should be generally family-based? Does it need to be modeling there for that? Or what are the options in terms of intervention for pediatric NASH? Dr. Mann.
Yeah, okay. So I think that there was an interesting piece of work that came out, which was a big collaborative work that I think came from North America, where they reported a survey of about 500 pediatric gastroenterologists and their experience and what they did and thought and how they managed pediatric NAFLD. And they sort of summarized the key barriers to effective management. And one of them, well, there were lots in there, obviously, but one of them was having an effective measure to achieve family-based interventions, because part of the problem is people aren't, it's a silent condition. So these children are coming feeling generally completely well, or at least in the UK, the way it is, this child may have been picked up because they were having blood tests for something else, and the next thing they know, they're in a specialist clinic, and then the next thing they know, someone's telling them, you're fine at the moment, but you've got to make these massive changes to your lifestyle. And then if you're going to turn around to the parents and say, you've got to do it as well, then that comes as a surprise. And then, at least for us, we're then shipping them out the door after 10 minutes, then trying to get the next one in. So it's sort of unsurprising that we are unable to facilitate families to make major lifestyle changes. So family-based intervention is certainly a good start, but I think what Gina was saying about going out into the community is arguably more important, because we as pediatricians would only ever see the tip of the iceberg. This is a silent condition which is highly prevalent, and therefore really it will be almost societal changes which need government or local government-led interventions and policy changes in terms of composition of foods, really to make a big intervention to make those family-based lifestyle changes easier.
Dr. Panganiban, your thoughts?
Yeah, I mean, I'm a true believer in family-based teaching. And actually, Dr. Mann had mentioned that study, and I was actually part of that study looking at, the pediatric gastroenterologists across the U.S. And, I was one of the co-authors for that. And so it's unfortunate to say that despite, the NASPGHAN guidelines that were put out in 2017, we really, if you ask all of us, we still manage and diagnose even NAFL differently. And we give every single patient, I think, a different message, and which is kind of unfortunate, in a sense. But I do agree that in terms of what Diana had said is that, in terms of family-based therapy, I think it's important because if I tell my son to go run outside for an hour and he sees me on the couch watching TV and not engaging, then I don't think he's going to follow my recommendations. Or if I tell my daughter, don't eat like that donut, and I'm eating one in front of her, then I think the message is kind of counterintuitive, right? So I think in general, we should kind of push to educate the whole family in terms of small behavioral, sustainable lifestyle changes. So in our clinic, we really focus on 1 to 2 goals at each visit, trying to ensure that they're compliant to those goals. And I don't really, it's kind of different where it's not directive care, but it's also like motivational interviewing, trying to figure out like what can they actually do at home that's feasible. I'm not going to tell them to go run 10,000 steps when they don't even run 1,000 steps, right? So I'm going to write it, kind of assess their baseline physical activity, their baseline intake, and based on that, make a decision with the family involved, like what is feasible for them to do individually and what is feasible for them to do as a family. But I do agree with Dr. Mann and, Gina, and saying that, that's really just a part of it. Really, you need education into the schools, you need education in the community, you need education of our government and their policies. So I think that all comes into play, but I also believe that it should start with the patient and their family to be.
And might I add, it also in Canada, it also starts with the access to primary care providers who can recognize NAFL and who will also can have a team-based approach to education in the community. Because in Alberta, you can see the fields behind me in my background. Well, we have a lot of geometrical space where there's not a lot of population with several thousands of kilometers. So primary care is really strongly talked about in Canada, and about educating physicians and other healthcare providers, not only to recognize NAFL, but to work in a team environment so that access to care is consistent. And that's something that still really needs to be worked on.
That's a really great point. I mean, a lot of what we're talking about here is also kind of able to be talked about general approaches to childhood obesity as well. And I kind of want to take that next step into diagnosis and treatment for fatty liver and NAFLD especially. Are there policies, are there things that need to be introduced to kind of give pediatric NASH a place on the map? I mean, whether that's for clinical drug trials, for funding, for research, for practice, what do we need to see happening specific to pediatric NASH as opposed to, say, more broadly childhood obesity? We'll keep going in order, Dr. Mann.
Well, from my opinion, I think that the key question that needs to be understood in order to then address your questions is to really know what the natural history of the condition is. And by that, I mean, if you see a child in clinic and they've got raised liver enzymes and they've got some increased fat on their ultrasound, it would be useful to say your risk of cirrhosis in 20 years is this. And basically, we have no idea at all. There are a couple of papers which have followed up a few children for a long period of time. They're the best we have, and they show that it is possible for children who have a diagnosis of NAFLD to end up with liver failure, but it doesn't really give you any numbers to go on. And I think that understanding that that incident risk is important to then inform whether or not you would want to take part in a drug trial, for example. I mean, taking part in a dietary study to me or a diet-based trial or a lifestyle-based trial would be, with my parent hat on, a more simple decision to make because the risk would be lower. Whereas if you're talking about, injectable therapies with potentials of side effects, and I think that it's important that as a community we really pull together to understand the natural history of this condition to decide, do we want to give drug trials, and how actively should we be chasing drugs to treat this condition as opposed to specific nutritional or population levels interventions?
Great. I want to come to everybody on this specific question as well, because that seems to be a very a great approach to dealing with kind of the next steps on this, from going from just general get some exercise and watch your diet to actually beginning to talk about that interaction there. Jennifer, can you expand upon that a little bit? What's your perspective on drilling down into treating on pediatric NASH and NAFLD?
So just to clarify, Jeff, you mean in terms of medications, or in terms of?
Yes.
Yeah, so I think it's kind of hard, right? So just like what Jake had said, it's, we don't know the natural history in children. There's limited data. I think, one of the biggest studies that we did was the tonic trial, which looked at vitamin E versus metformin versus placebo. They all got lifestyle intervention. And, they kind of extrapolated from that information on the kids that were on the placebo side. And what they saw is that about 60% of the patients either had the same disease, like their same NAFLD, NASH, or they progressed to fibrosis. So it's kind of hard for us to say that, I think there is a push in the community in terms of medications, because they want something that's an alternative to the lifestyle intervention. But when it comes down to it, I think the primary treatment should still be lifestyle. Because, it's through what we eat and what we do that makes it a big difference. And we know that NAFLD and NASH is reversible if lifestyle intervention is effective and when it's done correctly. Though difficult, it's hard to tell people you need to diet and exercise. I think everybody, has struggled with that personally. Myself, I've done that. But really, it's effective if it's done correctly. That being said, am I opposed to medications? And I think the answer is no, because I think there is a place for it. But you have to think about the population that we're treating. Children are very a fragile, population, that if we are going to do, drug trials on them, it should be in the right context.
Dr. Major, your thoughts?
Well, I mean, from a medication perspective, I think both Jake and Jennifer have already addressed that. Clinical trials for lifestyle modification aren't necessarily easy either to conduct in terms of adherence, especially longer term trials. But they are useful to do because they help you understand about adherence and whether or not someone can sustain a lifestyle trial longer term. Because as we know, lots of people yo-yo in their body weights. And I think if we had a magic pill, the creator of that magic pill is going to be a multimillionaire to exceed, many important corporate presidents around. So I do think they are important to do. I do think incorporating them with the family is really important. And I think with the virtual world we live in because of COVID, some consideration of how you might be creative about how to do home-based therapies, like that may be a positive coming out of that, because more and more people, myself included, are learning about virtual technologies. And so perhaps the consideration, instead of having to come into clinic, but instead to get the healthcare provider to come into the home through virtual technology, might help with some of those sustained changes that are needed in order to elicit the changes in liver functions.
So Gina, I'm wondering if you can chip in here a little bit. It looks like you were about to speak up. Let me not spoil that. Your thoughts?
Yeah, so obviously I'm looking at it from like a patient advocacy standpoint. I don't have a medical background, so I really cannot speak to medication versus lifestyle changes. But what I do believe is that the more, as we raise awareness and educate the general public, but I think as we get more patient stories out there and we can show, we don't want to scare people, right? But this is a serious disease and it's silent, it's continuing to, raise, like the prevalence continues to increase. And I believe that being able to show and use patient stories, whether they are children or even adults, and show how this can progress over time and what are specific lifestyle changes that you can make. I kind of look at it, I often compare it to smoking. A long time ago, they started to go into school. We started to go into the schools and educate children on the dangers of smoking, and then children took that back into the home. Some people realized, the consequences of that and what that could potentially, progress to. some people decided to not make those changes, but really showing like a specific path. And that's one of the things we created was like a fatty liver roadmap, we call it, that my dad, although he's not a child, he kind of went through this and he didn't know. He was told lose weight, exercise more. He had been told that his whole life. And I think that's what you see a lot when folk, you know, when especially children are obese, and being able to give a clear path on here's how this can progress and here are the lifestyle changes that you can make. I think just really, again, helps with that education, helps with that awareness. And that's where we really believe that our role as a nonprofit organization comes into play in working with, you know, pediatricians and doctors' offices and folks in the medical field to really kind of team up and kind of bring that perspective just to raise that awareness and education.
And can I add in something, sorry, about the schools? I really do think that schools need to be educated. Think about their cafeteria and their food environment and the fast food in their vending machines. I mean, in Alberta, we don't have sugar-sweetened beverages anymore in vending machines accessible in the schools. But ironically, about 3 years ago, we discovered that in our hospitals, we had vending machines with sugar-sweetened beverages, even while we were out in the community advocating. So of course that's changed now too. But I do think that Gina is right about awareness. And if we can, in pediatrics, it's not just the family, it's the school environment and the policymakers that decide what can be purchased for those school cafeterias and lunch programs or breakfast programs. Those are also really important. And I don't think NASH is on their radar at all. I mean, I may be incorrect in different regions, but globally, but in Alberta, the awareness is just starting to happen, like in the schools, because there's been some effort to try to promote that.
And if I may kind of piggyback off that, that's one thing. I believe you're correct in that we see that in the US from what we have seen. And we created a program at NASH Knowledge called CLEAN, and it's children, liver, education, and nutrition. And one of the things we're trying to do is get into the schools. You bring up a great point about, you know, the cafeteria and the food that is provided to the students, but also, you know, working with the teachers and the school administration to start that education there as well. So I think that's a great point. And that's where we believe that we can really kind of start and make an impact and really start to educate children in the schools, educate the administrators, the teachers, and really start to kind of team up and work together to really, you know, make a change and a difference and really help the health of, you know, our future generation.
No, I mean, I agree with Gina. It's like quite difficult for my patients. Like, even if I give them a letter to let them know, hey, you have fatty liver disease, you know, bring this to your cafeteria, to your school, let's alter your diet a little bit, I always get pushed back. So I think it's really, you know, education. I think the number one issue is buy-in, right? Buy-in from the kid and the family and the community that, hey, number one, I have a liver disease when I have no symptoms and I was identified on screening. And how serious is this liver disease? And then secondarily, what? You're telling me to go on a diet and exercise? Really? And then it goes into lifestyle intervention, right? So why am I going to do that? To lose weight? I don't need to lose weight. And it's kind of, you know, then it comes into play like culturally. So I think the focus is always about weight loss, but really what we're trying to like shift that towards is really, it's not really about weight loss. It's like about what kind of lifestyle intervention do you need to treat your liver? And I think that should be the focus, but it gets lost in the message that, oh, I just need to lose weight and that's why you're seeing me. And so then, and they don't remember that they see me because of fatty liver disease. And I think I try to, like, each time I see my patients, I try to remind them of that. And I think going into the schools and educating them early is important, especially since the prevalence seems to be higher in kids. And we're just not picking that up as early because we're only screening kids who are older.
I think that the communication of risk is very difficult because, you know, almost similar to, you know, COVID-19, at an individual level, the risk may be low for certain groups of you know, serious disease, but at a population level, it can have a large impact. But for certain individuals, for example, if you identified a child with substantial fibrosis, then you could say that their risk of progression is actually quite high. So, and with our current techniques for sort of staging or giving anyone an idea of severity, really we're limited to liver biopsy. There are other techniques that are available in terms of blood tests and scans, which give a reasonable idea, but none are completely accepted. So in general, when you're seeing someone, even in the clinic, which, as I say, mostly is a tiny fraction of them, we still have to be quite vague about their risk of long-term liver-related outcomes. And then if you were to go to, policymakers and people who are able to make structural changes, societal changes, then communicating the fact that 10% prevalence in kids, but it will be some tiny fraction of that percentage that would end up with long-term liver-related outcomes. And most of their outcomes in terms of morbidity and mortality will be heart disease and stroke and diabetes. So communicating that spectrum of risk is very difficult. And, patient stories is certainly one way to highlight the kind of top end of that risk.
Yeah, that's interesting. I mean, we have, what we're dealing with is really kind of a downstream effect of childhood obesity, where we have to deal with the individuals and the chronic diseases that have resulted as a result of that. And each of you are pointing out to several systemic things that happen, whether it's going to be the inability to access healthy nutrition, healthy foods, whether it's inability to access safe environments for physical activity. We do know from lessons in pediatric disease that generally that children with pediatric disease, especially those associated with childhood obesity, tend to become adults with those diseases. And I'm curious as to what everyone's thoughts are on what should happen when children and young people then transition to adult-based care. Is this something that, how does that happen, in terms of continuing, weight loss is only as good as weight management is, and the same for nutrition, other aspects in clinical care. Just let me lay that down and leave it out for your thoughts on that. How do we, what should happen when young people transition to adult care for fatty liver? Dr. Major?
Well, in Canada, there is a plan. It varies amongst the provinces. The major consideration is access to a service that can see the client or the patient in a timely manner. That's challenging in adult transitions of care. So an important factor I still think remains that is trying to connect with the primary care providers, where the individual is able to access a team-based approach for lifestyle change and for medical management of NAFLD. I think that's really, really important, because access to the specialty adult specialty liver services may take some time in that transition to occur. And also, I guess, both Dr. Mann and Jennifer should comment on the urgency of how that might be prioritized in the adult hospital, NAFLD, and whether or not that would be prioritized in the adult liver service compared to maybe some other liver problems.
Great, jump in, guys.
So in terms of the UK, when we see kids in the gastro or the liver clinic here, then to be honest, 98% of them with fatty liver would be discharged from secondary care back to their primary care physician at the point where they would become adults. The adult services have a lot of work to do, and obviously have a lot of patients, and they have a much better risk stratification system than we do. They will do their bloods, pop them into these scoring systems that are available that gives them some indication of risk. If they're seeing an 18-year-old, well, they get a low score because age is a major factor in those risk algorithms. They can use FibroScan or something else, and it's only a tiny number. I can only think of two, I think, that we've discharged to adult care who've then been followed up by adult specialists, liver or gastro. They're almost all then managed by their general practitioners as adults. And again, in the UK, and as I expect probably is similar elsewhere, unless those individuals, then young adults, have overt type 2 diabetes, they will be unlikely to be seen at a particularly high frequency by their general practitioner, because they will feel well and will have obesity, and they might intermittently have some LFTs done. But sometimes it feels like, we're trying to very actively manage these young people, and then they get up to the point of transition, and then it's like, well, in terms of compared to our 50-year-old who's got type 2 diabetes, who's at high risk of liver disease, then they just sort of go back into regular management. So I suppose I was interested as to what happens elsewhere, and should we do something else?
Dr. Panganiban, what are your thoughts?
Yeah, I mean, transition is always hard. I think even in the GI world, even for my IBD patients, right, who need to be seen by an adult provider, that's kind of changed over time, because we've made it our priority in the past few years we actually have a transition clinic, meaning that we've, identification of patients who need to be transferred usually should start at age 12. And that's kind of like our consensus. And so we identify patients early on. We kind of established, the tool. We try to give them the tools that they need so that they can transition well. Now, that being said, a lot of our families don't want to transition because they've been handheld and smothered with love and TLC in the pediatric clinic. And when they go to the adult world, they're like, what? I have to fend for myself. I have to make my own appointments. I have to do all these things. So as part of our transition group, we've actually identified, what tools do they need, and it goes into age stages like 12 to 14, 15 to 17, and finally when you're 18. And these patients are actually flagged on each visit for the provider to discuss that they need to be transitioned. And then specifically for NAFLD, there really isn't a transition program in the US that's been established, but we just started one at CHOP and Penn this year. And how our transition program is specifically for local patients is that aside from identifying that they're ready to be transferred, within a year period, we do a visit between pediatrics and adults, and then we transfer back, and officially then we relinquish care to the adult provider. And so that is a goal of ours to continue to do that. But is that available all throughout the US? No. And it goes back to where the primary care provider is the person who's really taking care of their disease when they become an adult.
Awesome. So I'm curious about your perspective on this, Gina, but we've got a little under 10 minutes to go here. And so I want to, I'll make up for not being able to get your answer on this by starting with you for this. With a little under 10 minutes to go, I want to make sure that we hit everybody here. To conclude the panel today, let's kind of go around the Zoom for one last takeaway from each of our panelists, okay? So a child has been diagnosed with NAFLD or NASH. What is the one takeaway for parents that are hearing this today? Gina, you're up.
I believe from what we've seen and just talking with folks, out in the community, that it's really making them understand how serious this could be, and making them, again, it goes back to me, like to the awareness and education. So educating folks and parents on what is this disease? What are the risk factors? What are the steps that you can take, specific steps and actions to, really help your child try to reverse this disease, try to prevent it in the future? And just, it really is education. That's what we found, that a lot of folks don't know what this NAFLD is. It's becoming more common, but in the general public, it's not well known. So I don't, in certain certain scenarios that I've been aware of talking in the community, it's kind of, again, lose weight. So I think it's giving specific actions and steps is really the key, and educating parents.
Dr. Panganiban, let's go to you next. What's the one takeaway?
I wish there was just one takeaway, but I agree with Gina. It's everything that she said is correct. It's like, really that, fatty liver disease is a serious disease. Lifestyle intervention is effective when done. And I think, but that can't be done without education. Education of the families, of your patient, of your providers, your peers, your community, and about, the government who does all our health policies. And it really starts there.
Okay, Dr. Major, quickly, one thing.
I think it's really important to know that lifestyle modification can seem like endless amounts of changes you have to make. So I would say from a patient and family perspective to focus on one change at a time. So as not to be overwhelmed. You can make those changes. And if you do, I think from a family perspective, you'll be doing it together. It won't seem as big of a obstacle or challenge to face. And I think that's really important for adolescents and for children. And the other thing I just want to make sure your adolescent has a say in those changes, because they're not going to listen to you as parents if you just dictate to them. They need to be engaged in that process as well.
Absolutely. Amen. So say we all. Dr. Mann, last one thing, take away.
It's like curveball here. As my one takeaway is that this diagnosis is almost not about the liver so much. For most people who have a diagnosis of NAFLD, and this includes children, their long-term risk is heart disease, stroke, diabetes, and the management initially is the same, lifestyle based. So if we're struggling to communicate the risk of liver-related conditions, then more people will probably have heard of diabetes and heart disease. And I think it's important to communicate that, as well as effectively giving them this diagnosis of their liver, we're saying you're unfortunately at high risk of other comorbidities that are related, and we need to think about those as well.
Wow, this is just dipping our toe into an ocean of conversation around this issue, and there's going to be a lot more going on with this. Certainly, we've seen the rise in childhood obesity, and we see the rise in NASH and NAFLD. I thank you to Drs. Major, Mann, and Panganiban, and to Gina Madison from NASH Knowledge for taking time out of your days to participate. I really look forward to continuing this conversation with each of you. Now, I want to encourage our viewers to check out the other International NASH Day panels. Coming up next at 11 a.m. Eastern Time here in the U.S. is NASH and Obesity. Information on this and all our International NASH Day events, including an interactive map of our partners and activities. And I mean, get this, that's more than 80 partners in over 25 countries right now, can be found at globalliver.org. And don't forget to join the conversation on Facebook, Twitter, and Instagram at #NASHDay. Thanks again to our panelists, our viewers, our sponsors, and our endorsers. I'm Jeff McIntyre with the Global Liver Institute. Stay safe, be well, love your liver, and we'll see you soon. Thanks.
Thanks.